One of the expressions that I makes me cringe is we tried a root canal.
Hello and welcome to Mommy Dentist in Business podcast. I'm your host, Dr. Grace Young. Welcome back, everybody. Thank you for being listeners and part of our community. We are downloaded in over 44 countries, and we're grateful for all of the doctors and our dental colleagues that tune in. Today, I have a special guest speaker who is nominated by one of our very own, Dr. Sadie Messman. And our guest speaker today is Dr. Stephen Bender, Diplomate and Diplomate of the American Board of Orofacial Pain. Welcome to the show.
Well, thank you. Thanks for having me. It's quite an honor.
Oh, no, the honor is ours, and we're excited for our community to get to know you. If you wouldn't mind telling everyone a little bit about yourself, what you do, and how you got to where you are today.
Okay, and this is kind of a long journey, so it could take a while, so I'll try to be brief. I graduated from what was then Baylor College of Dentistry, now Texas A&M College of Dentistry in 1986. As long as I can remember, I wanted to be a dentist, and I wanted to be a general dentist. So I kind of scooted through dental school, went out into private practice, just like I thought I always wanted to do. And it was great. I loved it. I loved restorative dentistry, went to Dawson Academy, Pankey Institute, started treating a lot of TMD or different types of facial pain and actually started getting a lot of referrals from some of my colleagues that I met because they thought I probably knew what I was doing, even though I probably didn't in hindsight. So after about 12 years, I just serendipitously got a flyer in the mail, and it was from the University of Florida. They were having, I can't remember what they called it, but it was a series, a continuum, a series of courses on orofacial pain. And when I looked at the flyer, I thought, man, that's a lot of stuff that, I haven't learned, but I'm really interested in, like headaches and, unexplained toothaches. And so I went there, and the director at the time was Dr. Henry Grimion. And I fell in love with what they were doing at the pain center. And Dr. Grimion was the best mentor in the world, he and Dr. Parker Mahan. And at the end of the series, the last thing that we did was what they called the mini residency, where we actually sat in on clinical practice and just watching the whole process and seeing how they changed the lives of some of their patients, well, most all of them, in a positive manner. At the end, I said, okay, I love this stuff. What do I do? And Dr. Grimion, again, just a blessing in my world, said, why don't you come do our fellowship? And at that time, it was not a CODA-approved specialty. This was back in 1990, maybe. I can't remember. And so anyway, he said, why don't you come do the fellowship? It's 2 years, and see what you want to do afterwards. So I did that, and he allowed me to kind of go back and forth between home and Florida on occasion because my family didn't want to move, and we didn't want to do that. And so at the end of that, I said, okay, now what do I do? He very kindly said, I've gotten to know you over these 2 years, and you're, obviously a really passionate restorative dentist because you've put all this time into, and he had a similar background. He said, you've put all this time into restorative dentistry. I know that you love it and that you care very much about it, but I've seen what you've done here at the pain center. And he said, I know you can't do both. So you need to pick one because my tiny little brain can only do one thing at a time. And as a restorative dentist, that's what I did. I didn't have multiple chairs. I just saw one person at a time. I hated to get interrupted by hygiene checks because I wanted to focus on the patient.
Sure.
So I couldn't do both, and so I just immediately decided to do orofacial pain. So I came back, sold my practice, my general restorative practice, and worked for another dentist that was a pain specialist in the Dallas area for about 3 years. I call it my extended residency because he didn't pay me anything. So after that, I decided to open my own practice, and everybody thought I was crazy. But I mean, right away, we were busy and enjoying what we did. Did that for, I don't know, about 15 years or so. And always wanted to teach because we taught in our fellowship program at the University of Florida. And so after a while, I started getting calls from the dental school here in Dallas, and they were trying to recruit me as faculty. And
Wow.
so I did that part time
Hmm.
for a while, and then I decided, I was just tired of running a business, to be quite honest, and felt like I would slow down a little bit going into academic world. And
Hmm.
little did I know that you don't slow down, you increase your
Yeah.
workload.
Yeah, I was going to say, but I mean, just to reframe or rephrase what you're saying, it sounds like you're the type of person that's just all in, right? Like you're 100% committed to what it is you're going to focus on, and you're going to do that and stick with it and be the expert in that area. And adding
Yes,
faculty commitments only made you busier because now the word is out and they know where to send the patients that maybe a
yeah,
lot of dentists aren't equipped or trained to treat just yet.
correct.
Yes. And so I wanted to ask you my next question, which
Yep.
really leads us to because you started out as a restorative dentist and
Yes.
there really it sounds like there's not a true specialty in which a dentist is best equipped to diagnose and treat orofacial pain. Is that correct?
Well, no. Short answer, no. There is now, we were the 12th specialty given by the ADA in 2020. So
Okay.
there is a specialty of orofacial pain. There's a board exam
Okay.
that we take.
Okay. So now during COVID.
Yeah, I mean, it was a process that started many years ago, and the ADA really, they had a different process of
Hmm.
recognizing specialists, and
Hmm.
it was a lot political, and they had to change that due to
Hmm.
some lawsuits by the anesthesia people and things like that.
Really?
So yeah, so now we're a bona fide specialty with, CODA approved programs and a board exam, two-part board exam, and so
Okay.
here we are.
Wow. So then for specialty residency program, I guess what is the title of the program?
So it's an usually, well, it's a orofacial pain, and different schools call it different things.
Hmm.
Postgraduate education in orofacial pain, and just a lot of different things. But
Okay.
it's called orofacial pain. That
Okay.
encompasses, TMD, other facial pain, sleep disorders, all sorts of things.
Okay. And do you think that it's offered everywhere in the US or just like
No,
50% or like,
there's probably 14 programs now out of 60 something dental schools, and so it
okay.
just hasn't made its way
Okay.
into a lot of schools. My school
Okay.
didn't offer a residency program, and I was there 10 years trying to push for that.
Hmm.
So it's all depending on what the dean of the school wants.
Okay. Is it competitive to get into?
It's getting that way. Now that it's a specialty, more people are looking at it as an alternative to general practice or other specialties.
Mhm.
Before then, people just thought, well, it's not a specialty. I don't really want to do something that's not a specialty. But now it's getting competitive because there aren't many spots.
Right. Okay. Wow. Well, I mean, you learn something new every day. I did not know that. This was
That's what I'm here for. I can leave now.
no, 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 no. Don't get off just yet. We've got some more questions.
Okay.
In a general practice, what steps should a GP take to treat patients with either orofacial pain? Because, and I was going to say temporomandibular disorder, but I didn't want to just leave it at that specific of a disorder because I feel that maybe, and I'm a pediatric dentist, so pediatrics don't have children don't have a lot of orofacial pain. So I wasn't going to assume that orofacial pain only stems from temporomandibular disorder. I'm assuming it could be many things.
Oh, absolutely. I didn't see many children in my practice, but I know that there are some that will experience temporomandibular disorders. But in general, it's mostly adults, and so these can be the atypical toothache, the tooth
Mhm.
pain that can't be diagnosed, can't be provoked. Endodontics doesn't treat it.
Mhm.
Trigeminal neuralgia, different headache disorders, um, movement disorders like uh, oral mandibular spasms and dystonias, things like
Mhm.
that, and sleep
Mhm.
disorders.
Mhm.
So we do a lot of different stuff.
So sleep disorders, like sleep apnea, can cause facial pain.
Yes and no. There's a lot of new data that suggests that poor sleep tends to precede the onset of a lot of pain disorders, and one of those would be temporomandibular disorders, but also some other facial pain. So a large part of what we
Okay.
do, and way back when I did my training, we mostly just tried to help people get sleep better. We weren't doing a lot with sleep apnea.
Okay.
Now it's a lot more sleep apnea. And so in that realm, we tend to work with the physician,
Mhm.
obviously,
Mhm.
and, kind of screen for other disorders, but work with the physician for these oral appliances.
Okay. Do you tie in prosthodontists too?
Um, yes, I worked very closely with a prosthodontist friend of mine. I taught in the prosthodontic department. But the bottom line is, and we can talk more about this, the occlusion,
Yep.
the arrangement of the teeth,
Yes.
have almost zero to do with temporomandibular disorders. And I know that's like heresy to say
Mhm.
that,
Mhm.
but the evidence tells us that is not really a major contributing factor.
So there is no
If
significant correlation of the way you bite and the way your teeth come
Yeah.
together.
Now, unless you change that, if you change the bite after a big restorative case,
Mhm.
then a person that has been adapting just fine to their malocclusion, you
Mhm.
change it to something else, and that person is not a good adapter, we call them. That can be from sleep disorders or a lot of other things. Now
Mhm.
they can have problems because it's different.
Right.
It's good, but it's
Right.
different.
Right. I can imagine because then the way your muscles come together and your face muscles, your joints and your jaw, like because you even a millimeter change can change
Hmm.
that neuro pathway and just with like I don't want to say neuroplasticity because that's not the right word, but just I'm sure everything is connected and that one
Yeah.
little change and one little modification can throw your system off.
Yeah, I mean, most people adapt just fine no matter what we do, just about. But some people are just not good adapters. And again, these are people that already have some kind of other pain disorders, irritable bowel syndrome,
Hmm.
chronic fatigue, migraine, all these different things.
Hmm.
I kind of explain it to people like, let's say you wear one kind of shoe, and you've worn it your whole life, one brand of shoe. You just obviously replace it when they wear out. And then you decide, I'm going to change brands. And it's a
Hmm.
really good shoe, but it's a different shoe. And so the interface of your foot against the ground is
Hmm.
different. And so
Sure.
because it's different, maybe your feet start hurting, then your knee
Yeah.
starts hurting, then because you're not used to it.
Well, that's a really great analogy because I mean, my son who's 11, God forbid that I change him from Nike to OnCloud. And
Right?
it's like a big deal. And he's only 11. He hasn't even hit puberty. And so I could only imagine, for patients who have a slight change that could kind of disrupt their body, especially if they are sensitive. And I know, so knowing what I know about TMJ, and I myself took this Botox course in
Hmm.
Illinois, and I know, like, I didn't take it to introduce it to my practice at the time when I had my practices in Illinois. I took this because I like to take education, and I thought, oh, Botox, I'm going to learn it for myself and my friends.
Sure, why not?
And so, but we learned obviously that you are introducing it in a dental practice not for just for aesthetics, but help relieve pain due to clenching and bruxing, especially the masseters, and for those that have migraines. And so I read up on it, and I was going to ask you, how is botulism neurotoxin, how do you use it in treating TMDs and bruxism, or are you not using it at all?
Well, it shouldn't be the first choice, and I talked more patients out of it than we decided to go forward because it's expensive, it's not covered by insurance, and it works maybe half the time. So I would rather do conservative care that's has a lot of proven track record, positive record, and save it for the refractory patients. Now, the way it works is not what we think it is. It's we think we decrease the muscle activity, we solve the problem. Botox is probably more like a central nervous system pain medication. And this was discovered in the migraine trials. They found that we put it in muscles, but they saw that in animal models that it actually went into the brain and stopped the release of CGRP, substance P, all these neurotransmitters that produce pain. And so what they found is, well, let's put it in the muscles because the muscle tissue will hold it there, but the muscles are right by nerves. So we've got all these nerve areas where they put it by design. And so in TMDs, yes, we're decreasing the intensity of the contractions. Now, we don't stop bruxism. We decrease the intensity, but we're going to still have the same amount. And there's some people they've demonstrated that are more susceptible to pains, tend to have the more lower level of muscle contraction anyway. So bottom line is it works in a fair number of people. It's a good resource to go to if everything else is not working, and it tends to work in the central nervous system. Now, I would say if you're going to use it, always do it bilateral, but try to include the temporalis too, because there's been some studies that have shown just putting it in the masseters can cause temporalis pain. So there's your short answer, hopefully, on botulinum neurotoxin.
It just makes sense. I feel like there's it sounds like a few different or many more treatment modalities, and I wanted to throw in because it's like a multi kind of system approach. I wanted to throw in the question of orthodontics because we were talking earlier about occlusion, and if orthodontics helps or hurts patients then with TMD, and where you go from there.
So orthodontics, or tooth movement, changing the bite, is what we consider TMD neutral. In other words, we used to think that it could help or that it could hurt. It's neither. I mean, it's in some people, again, changing the bite, even though it's a great bite, can cause pain. It can cause somebody that was not aware of a click to start having a click, and obviously they want to blame the orthodontist. And so part of what we do in orofacial pain a lot of times is try to present evidence in an understandable way and say, look, it's not this dentist or this dentist or this dentist causing you problems. It's you don't adapt well, and we need to give it more time. So again, long answer to a short question. Orthodontics is neutral. Now, I always told people, because they said, I'm thinking about going to see an orthodontist. Somebody recommended that. I said, well, if after you feel better, you want your teeth straight for cosmetic reasons, then by all means, go see the orthodontist. But it's not going to necessarily help. And it could cause you to have more flare-ups. So, again, we go back to the whole bite relationship, jaw relationship. That comes from the 30s and the 40s. You probably heard of Costin, James Costin, who was an otolaryngologist. He kind of brought this out. If we do certain things, your ear symptoms will go away, your hair will grow better, all these different crazy things. And people just jumped on the bandwagon and went with it. So we're really dealing with information from the 30s and 40s that is still perpetuated, but has no data to support it.
So how far back do you think, because, this kind of reminds me, unrelated but related, My anesthesiologist, my dental anesthesiologist that I worked with, I mean, he'd been doing it for a really long time, 40 years. And he would often tell me, Grace, by the time the research came out, he's like, I could have told you that anecdotally from all the years I've been doing this. And I'm like, no, it's true because someone's got to do the research, right? And if you have enough experience over like 40 years, you're like, yeah, I could have told you that. How far back then would you say orofacial pain has been researched and tracked?
Well, I know at least since the 60s and 70s, there's been some pioneers in the world of just pain, but also dental psychology, dentists that went on to get psychology degrees but also neuroscience, dentists that went into neuroscience. So it's been around for a while. Mm-hmm. And you make a really good point. In dentistry in general, it started out kind of as a trade. It's separated from medicine. And when it's separated from medicine, it's like we took our scientific cap off. Mm-hmm. And so, we constantly hear, well, I've been doing this for 40 years and it always works. And I always want to say, well, do a few more and it will stop working. I promise you that, because it's all I've done for, 25, 30 years. You're going to have failures. So, we have to get out of the mindset of it. Well, it works in my hands, or it makes sense to me, or this is the way Dr. So-and-so taught me, and take a step back and look at the science. Why? Because we can eliminate some of what my mentor, Dr. Grimion, used to always say is well-intentioned but misguided care. In other words, we have good intentions, but the care sometimes produces more bad things than good things and, costs more, et cetera.
Right. And sometimes you can't even predict that.
No. And it's because, we're trained a certain way. See a problem, fix a problem, without really considering, hey, there's a whole person connected to this. I better get to know them. And that's what I always try to tell the students. Get to know who's sitting there before you start working, because if they've got a history of migraine, irritable bowel, chronic fatigue, poor sleep, there's a good chance if you do a procedure, they're going to have persistent pain after that, that is going to look like, I don't know what's going on. My root canal looks perfect, and all these other things. And they're going to start taking teeth out and, I could go on and on. But I won't.
No, I think it's true, because I think I completely agree with you about getting to know the patient and not, I'm not saying on a social level, like, what are their habits? Like, what kind of foods are they eating? What time do they go to bed? Like, how much stress? What type of work are they doing? And I think that knowing their medical history, because a lot of times patients don't put a thorough medical history, and then you kind of coax it out of them eventually. But I think that you're right in that we have to see the patient as a whole and continue to do the blood pressure ratings, continue to, ask them about what was their recent blood work like, what is their A1C, what is their cholesterol, because I think that paints a bigger picture, and it's more telling, and the more information you have, I think the better clinician and more helpful diagnosis. And you had mentioned root canal therapy, so I wanted to tie that back in, because you had said, as dentists and students, we're problem solvers. We like to solve the issue, solve the problem, especially if it's black and white. And a lot of times I feel like it's not always black and white. And if a patient comes in with tooth pain and you test it and it's warranted to do a root canal, and you do the root canal, but there's still pain that persists, then where do you go from there?
So one of the expressions that makes me cringe is, we tried a root canal. And I always want to think, well, why'd you try it?
Right.
What was your diagnosis before you tried it?
Right.
So when we have any insult to the tooth at all, there's a natural response of inflammation in the periapical tissues. Now, the blessing is that most people, that goes away soon after. So that could be getting a new electric toothbrush. That could be having just a single surface occlusal filling. Or it could be extracting a tooth or a root canal where we're actually cutting nerve tissue, creating inflammation. So if you do a root canal and it doesn't seem to, now what will happen is, I'll take a step back. What will happen is maybe the patient gets relief for 2 to 3 weeks. And you're like, I did it. I fixed it. And then the pain comes back and you're thinking, it couldn't, I did a great job. And you do all your testing and well, then it's the other tooth. It may be the next tooth and we'll do that. So what you have to do when that happens is take a step back and think, what else could this be? So what does it feel like now? Is it the same as it felt before? No, doc, it's more of a constant burning type pain. Whereas before, I could feel my heartbeat. It'd wake me up during sleep. It's not waking you up? No. It's there when I wake up, but it doesn't wake me up. And so we have to listen to what they're telling us because the words they're using helps triage what kind of pain it is. And once they give us all that information and it is burning, stinging, sometimes electrical, then we have to think this is a neuropathic pain. This is not a dental pulp pain or need for extraction pain. So what do? In pharmacotherapy, we can try stuff. We can try anti-seizure drugs. We can try antidepressants, which we use to treat these nerve-related pains. If we get a response, cool. I'll treat it as the general dentist, or, if I'm not comfortable with this kind of medication, I'll send it to the orofacial pain specialist. Now, people say, well, what about the neurologist? Sorry, but they don't know that much about orofacial pain. They know seizure disorders, Parkinson disorders, things like that, but they don't study headache or other pains. And so the orofacial pain specialist is probably best if you have one. Mm-hmm. So you just have to, again, getting back to your question, you have to take a step back and say, let's make a diagnosis. Let's start talking about the quality and character of this pain. What does it feel like? When is it there? What makes it worse? What makes it better? Things like that.
Well, it's funny because, well, not funny, but when I'm listening to you, I'm remembering some of my past episodes, especially with endodontists and their whole thing. And I've talked to many, their whole thing is the diagnosis. Mm-hmm. Every episode I talk to somebody, they say it is the diagnosis that is the most important part of the root canal. Right. And that's what I'm feeling is what you're saying to me right now.
So yeah, one of our biggest referral, a lot of ENTs refer to us, but a lot of endodontists refer to us as well. I speak to a lot of endodontic groups. In fact, I'm going to their big meeting coming up in April because they want to know. They want that help. What if all my tests are neutral or equivocal and I can't make a diagnosis? What else could it be? Mm-hmm. And so we try to get them. And I think most endodontists, by all that I've met, are extremely good diagnosticians, and turn away more root canal treatments than they probably take on. Although they're plenty busy, but I think they're extremely good at diagnosis.
I would love to ask you another question. I could probably ask you 20 more, but I'm not going to because we are limited on time. But as far as children's cases, what have you seen come your way or maybe at the dental school when it comes to children?
So as far as the child themselves, what people would bring to me would be constant or chronic ear pain that eventually the otolaryngologist would say it could be the jaw joint. And so we would see that because pain is going to be different in children, as you know, yes. And it's going to present differently. They're going to express it differently, and we need to treat it differently. We need to understand that. Now, as far as what do we do? Well, it's very limited, at least it was for me, what I would do. So I would work with different providers, like a good pediatrician, pedodontist, or otherwise to try to manage them. Because as you know, you can't just throw a device in there or do things like that because you're going to cause problems down the road with growth and development. So that was the main thing. But indirectly, and I'll try to keep this brief, indirectly with my patients who had children, one of the primary things that I heard was about sleep disorders. And mm-hmm. So these parents would come in, I'd say, how's it going? well, I'm not feeling that great and this and that. And so the beauty of a facial pain practice is you can just kind of sit back and say, tell me what's going on. So you get to talk to your patients.
Mm-hmm.
And they would tell me about the problems their children were having at school, daycare, whatever, that they don't know what's happened, but they've gone crazy. And so they've been to all these different people, psychologists, whatever, and they can't figure out what's going on. And all I did was say, do they snore?
Right. Right.
And well, I think so. Get a sleep study.
Okay.
They would get the sleep study, the child would get treated, the parent would come back bawling,
So
you
happy.
changed our life. I've got my child back, and you changed, they're a different person. So that's the primary thing that we saw. And actually, not even my patient, but one of the most rewarding things that I did was help parents with their children get on the right path just by getting a sleep study.
Absolutely. And, for me in my clinical years of treating children, often we had to have a team of pediatric ENT, especially assessing tonsils. I find that pediatricians don't look far back enough. So if I diagnose kissing tonsils, they're not sleeping well, they're adenoids, they can't breathe, the whole 9 yards. Are they wetting their bed? Everything. And then I send them to pediatric ENT, and they do either a full, take the tonsils out, or adenoids fully or partially, whatever. Like you said, the parent comes back like, my kid's a different person. Like they put on, 5 pounds. Now, they're performing well at school. We're not taking ADHD meds. The whole life of this little human being changes if they meet the right provider. And so I think it's so important to be educating our colleagues. It doesn't matter what specialists, all colleagues who are treating patients should be asking these questions. And, part of my mission is to help educate using this podcast so that doctors can at least get a taste of it, and then they can go deeper by contacting doctors like yourself that are educators. So my last question is, I know you'll have to come back. Maybe you should do a webinar and show us some slides. What is your number one piece of advice on what you do to find balance between your professional and personal life?
So I would always tell my students and anybody else that would listen, I'm the wrong person to ask. I know up here, but I turned into a workaholic like my father. And I thought I never would. We learned at the Pankey Institute even before that we need to keep a balance. Work, play, love, worship should be equally distributed in our lives. And I didn't do that very well. And so what I try to do later on, and it's much easier now that I'm retired from clinical practice, is just try to focus on those moments, that we all talk about, because as you get older, you realize you don't have the time you thought you did. Yeah. And so you just have to focus on those moments, focus on the people that matter the most, but also your work. Now, one other thing, it's really hard, especially in facial pain, is to not take that home with you. You get so emotionally invested in your patients and wanting to help them, but you have to not take it home. When you go home and you walk through the door, you belong to your family and not the patient. Again, I did this horribly throughout my career. And so, I can look back and say, that's the things that I did not do that I should have, is leave it at the door, treat my family as if, because I was always on with my patients, but then I'd get home and just shut down. And that's not fair.
Yeah, it is tiring, and as the mommy dentist group, as moms, we actually, admit to one another. I feel like it's a confession. We drive home from work and then we sit on the driveway in our car for a good 10 minutes before we decide to go inside the house. Well,
and maybe that's something you need, is just decompress, pray, whatever you do to put your mind and say, these people deserve all of me. And again, I didn't do that. And, paid the price a lot of times. But if I can give advice, No, no, no. I mean, everything's fine. But you look back and think that was selfish. That was selfish. And so, if you can start that early, it's kind of like I tell students, start saving early, but also start trying to create a balance early.
Absolutely. Well, thank you so much for spending time with us today, Dr. Bender. If you don't mind sharing maybe a way for listeners to contact you, whether it's email or a website, if you're open to it, that would be
Yeah.
wonderful. I don't know what is the best way.
Yeah. Email is the best way. And I'm always open for people that are looking for advice or, questions on different things. I I do still stay active teaching, and so I enjoy that interaction. So my email is I don't know if it's on anywhere, but it's just Stephen Bender DDS at Gmail,
Okay.
and
So,
it's B Stephen with a B
okay. STEVEN
E N B E
Bender
N D E R D D S at
DDS
Gmail. So
at
it's
Gmail.
relatively easy.
Okay, perfect. Well, thank you so much for sharing. And listeners, thank you for staying a part of our community and listening and being with us. And for those of you who are listening, our social summit is in the fall in September. So please check out our website at mommydibs.com and we'll see you there. Thank you so much. Have a great day, everyone.